And thank you for inviting me. I am a physical therapist, so the context around today's talk will not be surgical. And my background is clinical. I worked at the Glen Sather Clinic for 18 years, and in that time kept my alliance to the physical therapy school and did my graduate work, and now I'm full-time at the school. So my feet are firmly in the two communities, clinical and education. So I'm going to tackle a really big topic in a very short period of time, and hopefully give you a few things that you can think about perhaps a little bit differently about rotator cuff injuries. But let's just break it down for a minute, because it's a term, it's a name that we hear really commonly. But I think it is worth just reminding ourselves what that is. The rotator cuff is actually comprised of 4 muscles that really originate on the back, on this shoulder blade. And the cuff term comes from how the 4 muscles kind of converge together into a common unit and then attach onto the ball. So if you think about the shoulder joint as really being a ball and a socket, where the socket is the shoulder blade and the ball is the top of our arm, the rotator cuff kind of comes from the back, almost like a hand, and kind of really holds onto the ball. And in that has a really important role to stabilize the shoulder. So we often think about the rotator cuff and its pure role of producing rotation, but it has I would say, a more important role in actually stabilizing how the shoulder sits, okay? So keeping that in mind as we move forward. So how do we injure the rotator cuff? Well, multitudes of ways, but we can really talk about putting it into 3 general categories. First of all, overuse. Oh, that's not overuse, is it? Where'd that go? Oh, we're going backwards. Perhaps we'll just pretend that that first slide of that overhead worker is the one that came up. So let's go with that. So overuse, I mean, this is very common when you think about what I just said about how the cuff functions and how much it functions. Anytime our arm comes into any sort of overhead position, and if that's in a repetitive nature within your occupation or your play, then your cuff is getting used. And so we have lots of overuse injuries. We can have traumatic injuries, so thinking, I guess, primarily about our overhead athletes or individuals who, not just overhead athletes, we can be walking, fall, land on an outstretched hand. So we have that one incident that seems to be what starts all of our shoulder problems. And then probably an area that we maybe don't think generally a lot about is just wear and tear, but it's a considerable cause of what we see at the rotator cuff. And that is just as we age, that's a tissue in the shoulder that's really susceptible to wear and tear, much like our knees and hips would be in the lower extremity. So as a result of that, we end up with injuries like muscle strains, tendinopathies, so that same sort of pathology but affecting tendon, and tears, so the partial to full spectrum. And this, for anybody who's had a shoulder injury, will nod to this, but the impact of having a rotator cuff injury, particularly if you're talking about the tears, has a very significant effect on quality of life, and so much so that it has been compared to congestive heart failure, diabetes, and depression. So it's a problem that has significant consequences. And in fact, it accounts for, in this one particular study, 4.5 million physician visits in the USA per year. And the other point that's worth remembering is they affect across the lifespan. So we certainly imagine shoulder injuries in our young, active, in particular overhead types of athletes and workers. But as we age, that initial comment about the cuff degenerating, and you can see by the last 2 bullets here, that greater than 50% of individuals over the age of 60 have a partial thickness cuff tear. The good news is not all of those are symptomatic, but it's something worth remembering that your cuff over time wears and tears, and we'll talk a little bit about how we can maybe prevent those. So once you have an injury to the cuff, this is really what happens. First of all, we leave them. We're really bad with shoulder injuries. The average time from when you first start to have a problem, with the exception of those really, really sinister ones, is somewhere around 12 to 18 months before we really seek that help. Because we can, right? You can compensate, you can, thank goodness we have another one, and so this is what happens. Generally, patients will enter the system through going through their primary physician or their physical therapist, and then it's really a decision between non-operative or conservative management and operative management. There's lots of questions still about how to best manage the shoulder, but we can certainly say this first point with some authority, and that is that with the exception of large rotator cuff tears in a very active population, the majority of cuff tears benefit from proper conservative treatment for a minimum of 3 months' time. It's important, though, that we define what that conservative treatment is, and again, keep in mind I'm a physical therapist, so that's going to be my slant. It has to be active, and so we'll break that down on the next slide, but it has to be something where you're addressing the movement, the mobility, the strength, the support, looking a little bit broader than even the shoulder at some of the upper spine and the neck region. It will not be made better with a passive type of approach. Passive being heat, some of the modalities that we might use, those sorts of things. And so to that end, one of the studies, I belong to the Shoulder and Upper Extremity Research Group of Edmonton, and we're made up of 7 orthopedic surgeons dedicated to the shoulder and elbow, some rehab people, and some researchers. And this is a study we're currently looking at where we're essentially trying to answer this question. You know, when patients with cuff problems enter the system, which patients are the ones that really do need surgery? So what does that profile look like? What are those clinical markers or signs that we might pick up as health professionals that might give us an indication of, which patient not only, needs to be expedited to surgery, but kind of give us that hint of prognosis. And so far, we're seeing what we, hope to see, which is that the majority of patients do very, very well with conservative management. So active physical therapy, just to spout on that a little bit more, these really have to be your 4 main categories. When you are seeking help for your shoulder and you're, seeing your physical therapist, you want to make sure you're checking these off. So yes, there should be some address of reducing or managing pain. There should be something to address mobility, and that should be the shoulder region, but also the upper back and even maybe the neck. Strength, rotator cuff, absolutely. So remember, there are 4 muscles. So if you are told that you have a tear, again, that sounds horrifying, but remember, it's most often affecting just one of those 4, and so there is absolute benefit to working on the other ones. So it's not to be shied away from, with always sensibility. Shoulder blade, so remember the shoulder blade is your socket, so the muscles that support that stable base need to be addressed, as do the muscles in your upper back and your neck. So looking at sort of the whole kinetic chain of how we move, and then putting that into a functional model so it makes sense for you as a patient. So remembering that slide where we had the 2 arms, the conservative, non-operative, and operative, should you be in that group that ends up having a surgical repair, these are really commonly done. I'm not going to pretend to speak to the specifics of the surgery. In Alberta, it's most commonly done through an arthroscopic or a mini-open procedure. And following that surgery, you as a patient follow a very standard rehabilitation protocol, something our group has worked on for the last 5-6 years, is developing consensus evidence-based standard guidelines that all of our surgeons have agreed upon, and they've developed into cuff repairs, our Bankart repairs for our labral tears, our joint replacements, posterior labrum. So we've we've really kind of rolled with the model of kind of getting everybody to agree on what we should be doing, and we being surgeons as well as the physical therapists that are treating the patients. And so your goals are very similar. You're still always looking at pain management, mobility, and strength. Those have to be the big three that comprise your programs. But now the most important goal is, postoperatively, is to protect the healing tissue and promote that healing tissue. We have two randomized control trials that our group looked at that was a little bit more specific to this post-operative management of rotator cuff tears. One has been published, the other is just in review right now. And it was kind of an interesting finding. And so what we were really focusing in on was that initial 6 weeks after your surgery. And very traditionally, you might have had yourself or folks that you know that are immobilized into a sling period for approximately 6 weeks. And there's been a little bit of movement in most surgical procedures to, should we be maintaining that mobility or immobility for 6 weeks, or should we be promoting early movement? And as I get older and older in this profession, the pendulum continues to swing. But we tackled that question as well, and had some of our patients were randomized into the group where they were in strict immobilization for 6 weeks, and the other group we said pain has to dictate, but you are allowed to, if you want to take your arm out and brush your teeth, do a little bit of assisted work with your other arm within reason. So we certainly weren't telling these patients that they could go lift weights or they could completely abandon, but it was sort of that, if you feel well enough, sure, you can start moving that as long as pain dictated. So interesting for a couple reasons. There was no significant difference between those two groups at 24 months when we looked at range, strength, pain, or quality of life. In that initial period of time, the people that were allowed to move a little bit had a quicker return of range of motion, so perhaps a little happier start to their post-op period. But long term, so again at that 24-month, that's how long we carried the study out for, there was no detriment to the final shoulder strength and repair. So the actual tissue was preserved. There was no increased risk of re-tear or anything that we would worry about surgically. And so you can look at this two ways. And from a physical therapist point of view, we do always have those patients that when they are in that post-op 6 weeks, they almost are carrying their sling around. They've got it around their neck, but they're swinging their arm, and you just know that, this is a patient that for lots of different reasons probably can start doing a little bit of movement within reason. And then there's some patients that they're just not. Either pain is predominant or the repair is such that the surgeon just wants to be really careful. And so we'd like to interpret our results that way, in that it really still promotes that patient-specific choice with the surgeon based on what the tissue integrity is, how the patient's response is, what other things are going on. But you can be rest assured as a patient that no matter which path you take, it would appear, based on our results anyway, that at 2 years they're all going to be about the same anyway, and that's good, okay? So having said all of that, really, this is what I want you to leave you with, and that is that the best way to treat rotator cuff injuries is to, anyone want to shout out what they think the answer is? Oh, I like that you said exercise. That makes me happy. But guess what? It's to prevent them from happening, right? Like everything. I know, smart Alec. So this really has to be a shift. It's sort of one of my soapboxes. We're doing lots of really good work in the knee and looking at preventing ACL injuries. We're looking at our seniors and preventing falls and doing all these sorts of things. In the world of the shoulder, where we are seeing an increasing number of our active older individuals with shoulder problems just because they're living longer and they're choosing to be active, I think we have to start looking at sort of shoulder prevention programs and really defining what that optimal shoulder health is. And so I've really summarized it here, but I think you can take this away and get started on it. So a healthy spine, that's where everything starts. So you must always think about your first link to your arms and your legs as having your spine. Healthy, mobile, and strong. Your shoulder, you've got to use it. So range of motion is crucial. We can't let the shoulder stiffen up. If it's given the chance, it will, and that's a whole other bucket of problems. So use it, stretch it, full range. And then strength. So we've got to look, and this might be a conversation you have with your physical therapist, your kinesiologist, or anyone that can help you with exercise. Good rotator cuff prevention exercises, looking at those muscles in the upper back and the shoulder blades. So I'd like for us to think about, certainly, and my work and my personal research was all on the overhead athlete, because boy, they give us lots of good stuff to work on in the shoulder. But I think we need to shift that a little bit so that we're also perhaps thinking about the longevity of our shoulders and aiming for this type of outcome into our 7th and 8th decades of life. Thank you very much.